All right, let's begin. All right, then let's start with the bleeding disorders. Today we'll finish platelets, WBCs, and if time persists, we will finish musculoskeletal में dermatology part. Okay, so let's just start. The first one, the coagulation disorders. In the last class, we finished with RBC disorders. Today we'll finish platelet disorders and WBC disorders. Okay, so let's just see coagulation disorders means here we'll be discussing about the platelet disorders. Okay. All right. So PT, INR, and PTT. So these three tests you need to keep in mind while you are solving the platelet disorder. These are very important, and based on this, you can easily make the diagnosis as fast as possible. Okay. So PT है. So PT means play tennis outside. It means extrinsic pathway का इसमें affect होगा and PTT means play table tennis inside. So what is extrinsic and intrinsic pathway? For that, let's go back to the basics. I told you that we will be discussing about this in the when we study the platelet disorders. So see, before beginning, let's just see this. This is very important. They will ask you one liner in this. How does actually the platelet plug formation occur? Okay, so each and every step here is important. First, there will be endothelial damage, vasoconstriction, then endothelin and everything will be released. VWF, one blood one factor exposed to collagen. Weeble Pollard body से release होता है VWF and alpha granules of platelets are also like secreted. Then addition occurs, then activation occurs, and then aggregation occurs. Now, what all happens in addition, what all happens in activation and aggregation, you need to remember because they will ask you the questions regarding this. Okay, they will give you a case of a researcher. Okay, why he researcher was performing or working on the project and he saw that this process was occurring. He saw these granules, like he saw calcium and ADP are released. So during what stage this is released and what all happens, you need to keep in mind. Okay, so addition में क्या होता है, activation में क्या होता है, aggregation में क्या होता है, you should be knowing it. Okay, coming to the coagulation and kinin pathway. For now, just keep the kinin pathways aside. Okay, kinin pathway को side में रखो. Just focus on the coagulation pathway. Okay, this is the intrinsic pathway and this is the common pathway. And where is the extrinsic? This is the extrinsic pathway. Now see, if they ask you what all is included in the extrinsic pathway, you will include this and this part. Okay, तो फैक्टर 7 से लेके 10 और ये जो भी है 10 to 112, all these are included in the extrinsic pathway. But if they ask you, if they ask you what is there in the intrinsic pathway, then you will be focusing on, okay, then you will be focusing on this part. 12, 11, 9 years and 10, 10, everything will be under intrinsic and here everything will be under extrinsic. Okay, this is the extrinsic pathway and this is the intrinsic pathway. So if in the question they might ask you कि we just saw TPT and PTT. Okay, so play tennis outside, so it means it will be focusing on the extrinsic pathway. So this is the pathway over here. If play table tennis inside, that is the intrinsic pathway. This is what they are trying to say, extrinsic and intrinsic. You need to keep in mind what factors are involved where. Okay, this is the simple thing that you need to remember. I would suggest you remember this pathway. This will help you in many ways. Okay, so this was about the coagulation cascade, PT and PTT. What else? What you need to remember. Moving ahead, we have vitamin K dependent coagulation. Okay, now this is also very important because in this diagram they have explained it beautifully. He reduced vitamin K, how it is activated by the enzyme epoxide reductase, and then what they will do, they will convert this into this. So this enzyme is very important, gamma glutamyl carboxylase. Okay, all of this we have studied in the biochem part, but there we didn't study in detail. While we were doing the vitamin K, all of this was written in one word. Okay, so this is all vitamin K dependent, and these enzymes are vitamin K dependent. That's why we studied them in the biochemistry in the vitamin K part. Now all days, okay, all days, now what will happen to them, what they will do. So these are the clotting factors. Okay, so they will go and lead to the formation of thrombin and all, make a clot and everything. But these are the anticoagulants, CNS. Okay, so they will be acting here and they will be cleaving all. So this diagram is very important because sometimes they have asked what happens via the antithrombin pathway and what happens via the protein C pathway. Okay, so this you need to remember. And same thing, they have given you vitamin K deficiency is there, so there will be decrease in synthesis of factors 2, 7, 9, 10, CNS. Okay, don't forget CNS. CNS are also very important. They will act as an anticoagulants in the blood. Okay, so that's it, you need to remember this. And one important clinical point is there, neonates lack enteric bacteria which produce vitamin K. Early administration of vitamin K overcomes neonatal deficiency in coagulopathy. Okay, so this is all what you need to remember in the physiology part of the platelet disorder that we are going to study. Now let's just move on to the path, bleeding disorders. Yeah, so here we have bleeding disorders. I don't know what happened again. Okay, so let's just see. As we saw, PT will be looking out for the extrinsic and PTT will be for intrinsic. This is clear. Just remember this mnemonic: PT play tennis outside and pre-table tennis inside. Okay. So now let's come to the first type of disorder, hemophilia A, B or C. Now let's see, if it is A, there will be deficiency of 8. If it is B, there will be deficiency of 9. And if it is C, there will be deficiency of 11. So you know there is no factor 7 involved here. So it won't be extrinsic. It will be following intrinsic pathway. So if it is intrinsic pathway, what parameter you need to look out for? That was P double T. Okay, P double T will be increased here. And what else is? Yes, this thing. Hemorrhage in hemophilia, hematrosis, that is bleeding into joints, easy bruising, bleeding after trauma or surgery and everything. Treatment will be desmopressin. Okay, now here they will give you a case. Uh, bruises, bruises seen in infant. Okay, or you can say bleeding frequently seen in a boy. Okay, this is how they will be asking you. Nothing else you need to remember. Just remember this hemophilia that are released. Just remember that genetic. Remember the symptoms. And yes, hemophilia आ रहा है, then it will be only increasing P double T because factor 7 is not involved. That is responsible for the extrinsic pathway. Okay, remember this image because they might say bleeding internally in the joint, or you can say there is a swelling in the joints also. Anything they can say. Okay, just make sure you know them so you don't make it wrong. Now coming to vitamin K deficiency. Now vitamin K deficiency, almost all the factor 2, 5, 7, 9, C, S, everything is involved. Okay, so PT is going to increase because 7 is also an extrinsic pathway and other factors are also being decreased. So this PTD can also be increased. Okay, general coagulation defect, bleeding time normal, decrease in activity of factors 2, 7, 9, 10, protein CNS. Okay, that's it. Let's move ahead. Now here are some platelet disorders. Let's just see what do they mean. This page is very important because direct questions have been asked over here. So mark this page as very important for the platelet disorders because here what happened is they will just give you lab values and you will have to pick out which disorder they are talking about. Okay, so you need to keep this in mind. And what are the extra point I wanted you to write down? Yeah, here we have written that we will give desmopressin for treatment. So write down one point. Desmopressin increases VWF and factor 8 levels. Okay, desmopressin increases VWF and factor 8 levels. You need to keep this in mind. Okay, so this is important. Let's move on to this disorders. All platelet disorders have increase in bleeding time. Okay, mucous membrane bleeding, microhemorrhages, example petechia, epistaxis. Platelet count is usually low but may be normal in qualitative disorder. So let's just see what is happening here. The first one, that is Bernard-Solier syndrome. You have to remember the name. Along with that, you have to remember the lab value. Platelet count can be normal and decreased, but bleeding time will be increased. Let's see autosomal recessive defect in addition. GP1B1 platelet to VWF addition. If you have seen Bourgeon Beyond properly, they have explained the addition, aggregation, everything in very detail. Okay, they have explained everything in very detail. And still, if you don't understand, you can always go to Ninja Nerd on YouTube. Okay, so यहाँ पे there is a defect in addition. So you should remember this protein as well as what addition, platelet to VWF addition. Another thing, abnormal ristocetin test they will give you. The platelets will be large. And apart from this, they will add one point over here. Giant platelets plus thrombocytopenia. Okay, if you get this, Giant platelets plus thrombocytopenia. The question is talking about the Bernard-Sollier syndrome. Okay. Moving ahead, we have Glanzmann thrombasthenia. Sometimes what happens is they won't give you Glanzmann. They will just give you thrombasthenia. So you don't have to confuse yourself. Okay. Anywhere, if in step one question is asking about thrombasthenia, you should think about Glanzmann thrombasthenia, not anything else. Okay. So let's just see what is happening here. Autosomal recessive defect in aggregation, decrease in GP2B3A. Okay, that is decrease in platelet to platelet aggregation and defective platelet plug formation. This line is very important. Similarly, about this line is very important. Okay, they will literally ask you what is defect over here. Okay, or else they will give you the defect and they will ask you what is the name of the disease, name of the syndrome. Okay, so you should be thorough with this. Blood smear shows no platelet clumping. No clumping because there is no aggregation. Okay, so there will be no platelet clumping. Coming to the third type, we have ITP, that is immune thrombocytopenia. Let's see the lab values. Decrease in PC, increase in BT. Okay, bleeding time increase हो रही है, but platelet count यहाँ पे there will be decreasing. So decrease in platelets in spleen. This antibody you need to remember. Splenic macrophages, phagocytous platelet. Most common idiopathic, but will occur with disease. If in the question they give you any disease, okay, SLE or any malignancy is there, think about that. The question is asking you about ITP because ITP को identify करना is very difficult in the question. You will be confused. ITP है या कुछ और है. Okay, so ITP is very important. Just remember कि कोई disease है साथ में और malignancy है. You need to keep this in mind and your answer will be ITP considering you have this lab values given. Okay. So lab may increase in megakaryocytes on bone marrow biopsy, decrease in platelet count. Treatment is not necessary. Just remember glucocorticoid. Okay. That's it. Coming to the next, this is the new topic given in the 2022 edition. Wasn't there in 2020 and one. I'm not sure about one, but let's see. Uremic platelet dysfunction. It means the bleeding time is increasing, and yeah, it mostly happens in renal failure, mostly in chronic kidney disease (CKD). Okay, yeah, in patients with renal failure, uremic toxins accumulate and interfere with the platelet addition. So here also there is a problem in addition. Okay, remember this problem in addition. So guys, this becomes very important. This part becomes very important because one liners will be asked. They will give you the this where is the defect and you will have to identify, or they will give you the name of a syndrome and you will have to identify the defect. Okay, very simple, straightforward questions are asked over here. Coming to the thrombotic microangiopathy, similarly TTP and HUS. These are the two syndromes that you will be learning and but one important point here you have to remember is there will be normal PT and PTT. Okay, normal PT and PTT. That's why it can be easily identifiable from other conditions. Okay, normal PT and PTT आपको याद रखना है. Now coming to TTP and HUS, how you are going to differentiate it? First point is it occurs in females, whereas it occurs in small children. Okay, this is the first point of difference. Coming to second, see, triad will be common. Triad of thrombocytopenia, MAHA, and acute kidney injury. Okay. So thrombocytopenia, decrease in platelets, MAHA, you know, MAHA we studied in RBC, so there has to be helmet cells, that is schistocytes. It is a RBC disorder. It's a type of anemia. So hemoglobin also has to decrease. Okay. MAHA is there. So LDH and everything else will also be increased because it is a hemolytic anemia. Okay. So keep this all in mind. They will confuse you with all the lab data, unnecessary lab data. Okay. Coming to the acute kidney injury, it means the renal failure or whatever we studied in renal pathology. Okay. So this is common in both of them. This has to be common in both of them. What is the difference here is in TTP, there will be triad plus fever plus CNS symptoms, whereas in HUS, there will be triad plus diarrhea. Okay, this is how you will be distinguishing and why it will be confused, because sometimes the HUS they will give you in a female child, but they won't mention you the age. Okay, but you have to figure out based on the presentation if triad is there in both, but along with that fever and brain problem and diarrhea, you have to figure it out what is the question is talking about. Okay, now coming to pathophysiology. In pathophysiology, Inhibition or deficiency of ADAM-TH13 is important. What is ADAM-TH13 is important? BWF metalloprotease. Decrease in degradation of multimers, increase in large multimers, platelet hydration. This is very important. So many questions are there in NBME and UWorld. In UWorld, one question is there, but in NBME, so many questions are there. They have just asked you the mechanism. Okay. So this is what all is important. Similar points है, just 2 to 3 differences. Women, children. Triad दोनों में होगा. Here it will be fever plus brain symptoms and their diarrhea. Okay, and you need to remember the pathophysiology in TTP because of ADAMTS13, whereas in HUH it is because of Shiga like toxin, that is Escherichia coli. Okay, simple. So ये page is very important for the platelet disorders. Okay, moving ahead. Yeah, this page is also important because they are talking about the most important condition, that is DIC and VWF. Okay, along with this small one liners are also important. So let's just see. ये पेज को भी आप important mark कर लेना. All right, let's just start what they have given here. VWF and DIC. Yeah, one important point I forgot over here. Here sometimes they may confuse you. Normal PT and PDT is there, but they may say increase in D dimer. Okay, they may say increase in D dimer. So make sure you don't get confused. Okay, moving ahead. Now here VWF and DIC. First of all, you need to focus on the lab values. Lab values is very important because this is the only thing that will help you solve these questions and diagnose it. Okay, now coming to what is given in the notes. Intrinsic pathway coagulation defect. Decrease in VWF, increase in PTT. Okay, why intrinsic pathway? Because VWF has association with factor 8. Okay, now defect in platelet plug formation, decrease in VWF, defect in platelet to VWF addition, everything will occur. Important point, autosomal dominant. Okay, no platelet aggregation with ristocytin cofactor assay. This is important. This will help you in diagnosis. Treatment is desmopressin. Okay, there will be now I'll tell you how the case is presented. So case will be easy bruising plus skinnish bleeding, and most commonly they will give you menorrhagia. No joint tissue bleeding. Okay, so keep this in mind. And another thing is no platelet aggregation with ristocytin cofactor assay. Now in the question, what they will say is they will say that the patient's serum was mixed with ristocytin. Okay, and there was platelet aggregation. Now there are two things: if it is normal and if it is abnormal. If it is abnormal, you have wind Wellebron disease, and if it is normal, it will go on working normal. Okay, so this is how they will give you. They will give you the patient serum was taken mixed with ristocytin, and it was found out the poor aggregation and all those stuff. They will discuss blah blah. Okay, so just keep this in mind. Coming to DIC, you need to remember the lab values, of course, and what else you need to remember? Widespread clotting activation. Okay, so increase in thrombosis, increase in hemorrhages, maybe acute or chronic. Another important thing, causes. So causes may obstetric complication is most common. Then you have pancreatitis is most common, malignancy is common, and sepsis is common. Okay, so these four things are very common. You have to be aware about while you are making diagnosis of DIs. Okay, now labs. Apart from this lab, these labs are also important. Increase histocytes, increase in fibrin degradation, decrease in fibrinogen, decrease in factors 5 and 8. Okay, so both of these lab values are very important and they will be asking you both of them. Okay, now you can say there is schistocyte, so sometimes they may confuse you with maha also. Okay, they can say there is a maha also occurring in the patient, so you don't have to get confused. Okay, So all these are the platelet disorders. Few more are there, hereditary disorders. We will discuss them. Let's note this down. This is very important. All right, moving ahead. We have hereditary thrombophilia. Okay, hereditary thrombophilia. All are mostly autosomal disorders. Okay, resulting in hypercoagulable state. Okay, hypercoagulable. So let's just see one liners. These are one liner questions. Okay, so let's just see antithrombin deficiency. No direct effect here, but diminish the increase in P-double-T following heparin dosing. So in the question, they will say that a patient was on heparin. Okay, the patient was on heparin. So only two cases are possible here now. One is antithrombin deficiency, and other is heparin toxicity. Heparin induced thrombocytopenia. Okay, with this we will study in the heparin in the pharma section. So only two things are possible if the patient is given heparin. Okay, third one is the patient is being treated, but two things are either it can be antithrombin deficiency or heparin induced toxicity. Nothing else will be there for the heparin case study. Okay, it can also be acquired. We did this in the nephrotic syndrome. There will be loss of proteins in the urine also. Okay, so antithrombin can be lost there also. Okay, coming to the second factor 5 laden. Production of mutant factor 5 that will be replacing guanine to adenine DNA prevent mutation. This is the mutation that is resistant to degraded by protein C. Complications include DVTs and now see how they will present this question. They will give you this case. Either they will give you DVT or recurrent pregnancy loss, and and in the question they will give you this mutation, or else they will give you this clinical presentation, and then they will say there was a different deficiency in factor 5, and then you will be asked which mutation. Okay, so this is how they will be asking you one liners from this. Coming to next, we have protein C or S deficiency, inability to inactivate factors 5 and 7, increase in risk of warfarin induced skin necrosis. So here the case will be of warfarin, and what they will say there was skin induration or necrosis. Okay, so अगर warfarin लेने के बाद if there is skin necrosis or induration, you have to think about protein C or S deficiency. That's it. Okay, that's it. Now one syndrome here it is given that we'll be studying in of gynae, antiphospholipid syndrome, that is APLA syndrome. Okay, APLA. I am just writing down case presentation for you so that you can revise it here along. So diagnosis के लिए so you should be finding lupus antibodies, anticardiolipin. Now yeah, anticardiolipin. Now see how the case will be presented to you is either it will be DVT, CNS stroke, and recurrent fetal loss. Recurrent fetal loss is very important. Okay. And what else you need to remember is yeah, another antibody over here is anti beta 2 coagulant. Anti beta 2 coagulant is also important here. Okay, so this was about the APLA syndrome. We will study in detail in the reproductive part, but for now this all is very important. So this page along as well, the last one, I consider them as very high yield. One liners will be asked. Stay thorough with the lab values. Lab values is what going to make you a correct diagnosis. Okay, if you don't understand lab values, go back to the basics. But I would recommend not to waste time there. Just remember PT किसमें increase है, PTT किसमें increase है by just remembering the page layout. Okay, तो कर लो ये. And with this we are done with the platelet disorder. This is about the treatment that they have asked, but in the exam they never focus on this stuff. This upper one. तो let's just see blood transfusion therapy में क्या important है. Packed RBCs, not needed. Platelets, not needed. Yeah, fresh frozen plasma and prothrombin complex concentrate, increase in coagulation factor levels. FFP contains all coagulation factors and plasma protein, but PCC contains generally 2, 7, 9, 10 as well as CNS. FFP में all, but PCC में 2, 7, 9, 10 CNS that is uh, activated by vitamin K. Cryoprecipitate, fibrinogen, 8, 12, VWF, and fibrinogen. So these are the factors present in the cryoprecipitate. That's it. Basically, they don't ask this, okay? But they might ask you about FFP and PCC because in UL one question was there. Alright, we are done with the bleeding disorders. We are done with the platelets. Now let's move on to the WBC. Okay? Now platelets easy hai, RBC is easy hai. Most problem arise in determining the type of leukemia. Okay, the four types of leukemia: ALL, AML, CLL, and CML. This is the most tricky part of hematology. बाकी RBC and platelet disorders तो cakewalk है. Okay, so now let's just discuss about the lymphoma, that is Hodgkin and non-Hodgkin lymphoma. These are the distinguishes. You can just read them. They are never asked. Okay, now coming to the Hodgkin lymphoma. Okay. So what all is important in the Hodgkin lymphoma is Reed-Sternberg cells. This image should be on your fingertip. ये image को रट डालो. See this image. If you find these two cells, the owl eye cells. Okay, owl eye cells, that is Reed-Sternberg cell. You need to keep them in mind whenever this image pops up. Think about Hodgkin lymphoma. Okay, this is the only easiest way to diagnose. Another important thing, so instead of red sunburst cells, they will give you giant cells, bilobe nucleus with two halves as a mirror image, owl eye. Okay, RS cells are CD15 and CD30, B cell origin. Now go back to your immunology basics. B cell may I told you some CD markers are there. So all those CD markers they are coming to use now. ओके, वो सारे थ्री मार्कर्स अभी यहाँ पे यूज आएंगे, स्पेशली बी सेल मार्कर्स एंड टी सेल मार्कर्स, वेरी वेरी इंपॉर्टेंट. ओके, so CD15 and CD30 positive. So this is how the case will be presented to you. They will give you this image. They will give you this image. They will give you CD30 and CD15 positive. That's it. This is what your hint will be for Hodgkin lymphoma. Okay. Now, most common type of Hodgkin lymphoma is nodular sclerosis, and the best prognosis is seen in lymphocyte rich. That's it. Nothing else you need to remember here. Okay. So this two line is important for you to diagnose Hodgkin lymphoma. Now coming to the non-Hodgkin lymphoma. Non-Hodgkin lymphoma may you will be confused with the translocation that they are. And translocations are going to be little difficult to remember, but I have a mnemonic for that. You need to remember that as a mobile number and you are good to go. Let me just tell you. All right. Coming to the non-Hodgkin lymphoma, first let's just discuss and then at the end I'll tell you the mobile number. All right. Burkitt lymphoma, 814 is important. And the starry sky appearance, sheets of lymphocytes with interspersed tingible body macrophages. Associated with EBV, jaw lesions in endemic area in Africa, pelvis abdomen in sporadic form. Now see, 814 is important. This is the translocation that you need to be aware about. Okay. 814. Starry sky appearance is important. Jaw pain is important. Jaw pain. Okay. So these are the 3 points that you need to remember. And in this, sometimes they ask it कि T814 में 8 क्या है? So CMYC is 8. Okay. So this is how you will be remembering Burkitt lymphoma. Coming to diffuse large B cell lymphoma, that is DLBCL. DLBCL. ओके, तो यहाँ पे क्या याद करना है? BCL2, BCL6. Now can anyone tell me what is BCL2 and BCL6? Anyone? Quickly, I need the answer.
Apoptosis marker.
So they will cause apoptosis or they will stop apoptosis.
They will stop apoptosis.
Yeah, so they are anti-apoptotic markers. Okay. Hmm.
Anti-apoptosis, yes.
Hmm. So these are anti-apoptotic markers. Okay. Remember, I told you in one type of lymphoma while you were studying general path. So this is how they will be testing you. In the question, they will give you anti-apoptotic markers are present in this type of non-Hodgkin lymphoma. Don't get confused. BCL2, BCL6 is what they are talking about. Okay. The most common type of non-Hodgkin lymphoma is DLBCL. Okay. So don't get confused. Coming to follicular lymphoma, 14-18 translocation between the 14 and 18 is BCL2. Again, apoptotic marker is there. Okay. So just look. Either they are asking about the translocation. If they are asking about the translocation, think about follicular lymphoma. And if they are just saying apoptotic markers are present in the option, you need to look out for DLBCL or follicular. Okay. So let's just see. Waxing and waning lymphadenopathy. Can anyone explain me waxing and waning lymphadenopathy? Anyone? How they are presented in the question? Anyone knows? Okay, I'll tell you. What happens is in the question they will say either they will give you the direct waxing and waning lymphadenopathy, but if they don't want to give this, if they want to trouble you, what they will say, कि sometimes the lymph nodes were palpable and at some time lymph node were not palpable. Okay, तो कभी कभी palpable हो रहा है, कभी कभी palpable नहीं हो रहा है. So this is what painless waxing and waning lymphadenopathy. Waxing means pain हो रहा है and waning means going away. Okay, so they will use this fancy term directly if they want to make your life easy. But अगर वो आपको trouble करना चाहते हैं, they will give you in this meaning. Okay, so please note this down in your first aid wherever it is. This question is there in UL. They have explained vaccine winning as this description. Okay, moving ahead, we have mantle cell lymphoma 11-14. Okay, cyclin D1 is 11, 14 is heavy HG chain. Very aggressive patient typically present with late stage disease. Okay, just write this down. Coming to marginal zone lymphoma 11-18 associated with chronic inflammation. So, Sjogren chronic gastritis. Okay. Now, they will give you gastritis as the most common. Okay. Gastritis most common. Hai. So, if in the question gastritis is given and along with that they are asking you non-Hodgkin lymphoma, remember marginal zone lymphoma. Okay. These are the one word how the case will be presented to you. Okay. And this is only how you are going to remember. Coming to primary central nervous system lymphoma, you can ignore this. Just remember the toxoplasmids that will be doing it in the microbiome class. Now, the mnemonic for you over here is like a phone number. Okay, 8, 14, 14, 18, 11, 14, 11, 18. 8, 14, 14, 18, 11, 14, 11, 18. This is how you are going to remember. But बीच में याद रखना there is DLBCL also. Okay, so ऐसे याद करो 814 slash 1418 1114 1118. Okay, I remember like this, so you can also remember like this because this is what they are going to ask, and they will be asking you by giving the translocation, or they will describe you the case and they will be asking you the translocation. Okay, translocation is very important to remember. तो ये निमोनिक आप यूज कर सकते हो 814 स्लैश 1418 1114 1118. इजी टू से, दिन में 10 बार बोलो याद हो जाएगा. ओके, so this is all about the mature B cell lymphomas. Now let's see T cells में क्या है. In T cells, adult T cell lymphoma caused by HTLV. Okay, drug use के साथ आएगा. May present with cutaneous lesions common in Japan. Okay, cutaneous lesions common in Japan. So in the case they will give you a patient from Japan who settled in US. Like this they will give you. Okay, coming to mycocyte fungoid and Sézary syndrome, so they will definitely give you cerebriform nuclei. Okay, cerebriform nuclei definitely देंगे. and intraepidermal neoplastic aggregates. Okay, they will also give you portreal microabscess. Okay, so this is how you are going to make diagnosis for mycosis fungoides or Sézary syndrome, cerebriform nuclei, and portrait microabscess. These two words has to be present. Otherwise, these two are not most commonly asked. The main focus is this only. Okay, so done with Hodgkin and non-Hodgkin lymphoma. Hodgkin में तो एक ही है CD15+, CD30+ and Reed-Sternberg cell. Done with Hodgkin and non-Hodgkin, you have to remember this translocation का mnemonic and one line in each case. Alright, moving ahead. Plasma cell disorders. And another high yield disorders here are they will be asking you distinguish between multiple myeloma and Waldenstrom macroglobulinemia. Okay, so let's just see what is the difference here and what all you need to keep in mind over here. So plasma cell disorders characterized by monoclonal immunoglobulin overproduction due to plasma cell disorder. Okay, so this is the M spike, and in one of the NBME you had this question. Very first question of the NBME was this. Okay, so make sure you know this. Now, this all not important. Coming to our first important diagnosis, that is multiple myeloma, overproduction of IgG, and in Waldenstrom microglobulinemia, you have IgM. Okay, so IgM or IgG के difference पे you can do it. Second, in multiple myeloma, remember the crab features. Crab features are very important. Okay, crab features are very important. Here also they have given punched out lesion. Punched out lesion is same as the crew cut appearance. Okay, don't get confused. इसमें भी ऐसे ही कर देंगे. See, this is one of the region and see upon a hair भी है. Small hair growth, punched out region. Okay, so don't get confused. Crab and in Waldenstrom there won't be crab. No crab. Okay, crab present, crab not present. Apart from this, another important point in multiple myeloma, peripheral blood smear shows Rolex formation. RBCs tackle like a poker chips. Very important. Very important. Okay, this peripheral smear you need to remember Rolex formation or poker chip formation. They will give you. You need to remember this. Okay. Urinalysis shows Ig light chain, bench zone proteinuria with negative urine dipstick. So instead of bench zone proteinuria, they will just give you proteinuria. Okay, bench zones का होना जरूरी नहीं है. And your important point is yeah, bone marrow analysis shows greater than 10% monoclonal plasma cells with clock phase chromatin. See, in this it is not clear, but see if this is a plasma cell, this is a chromatin, तो इसके अंदर ना ऐसे clock phase होगा. There will be clock phase. So just look at the image clearly on the computer in the exam. If you feel any circle like ऐसा कुछ भी है अंदर inside this cell, think about plasma cell disorder. Okay. So first option should be plasma cell disorder, and second, if they ask what is the specific disorder, then you will say multiple myeloma. Okay, so these are the important points you need to keep in mind while you are doing multiple myeloma. Coming to Waldenstrom macroglobulinemia, no crab. So what is there? Hyperviscosity, headache, blurry vision, dryness phenomenon, retinal hemorrhage. Okay, यहाँ पे तो IgM ही होगा. So nothing else you need to remember. These are the differences between multiple myeloma and Waldenstrom macroglobulinemia. Now, one another condition is there, monoclonal gammopathy of undetermined significance. They will give you MGUS. Okay, MGUS दे सकते हैं without expanding the full form. Don't get confused that you haven't studied this. Okay, so overproduction of any IG type, कोई symptoms नहीं, no crab findings, nothing, just plasma cells. Okay, overproduction of any IG type. Okay, it can be G, it can be M also, but then you need to look out. Crab findings है, hyperviscosity symptoms है, नहीं है, then you go for MGUS. Okay, plasma cells तीनों में होंगे, but you just have to pick out the symptoms. Okay, so this is what about the plasma cell disorders, and this is also high yield. Okay, note this down. Moving ahead, myelodysplastic syndrome. One question is there in UL, but in NBME there wasn't any question. Let's just see what's the problem here. In stem cell disorders involving ineffective hematopoiesis. Okay, so non-lymphoidal lineage में maturation नहीं हो रही. Non-lymphoidal means B cell T cells normal है. बाकी सारे जो है all the different cell type neutrophil, eosinophil, acidophil, basophil ये सब में maturation नहीं हो रही. No maturation there. So how it can be caused? These are the causes: radiation, benzene, chemotherapy, risk of transformation to AML, more common in elders. Okay, that's it. Yeah. Oh, यार ये इसका problem. Yeah. So pseudo Pelger-Hewitt anomaly. See, in the U world, there wasn't any question regarding this. They haven't asked any question regarding this, but this name popped up in one in options. Okay. And as you know, if you are doing U world, if you are reviewing your U world, you have to look at all the options while reviewing. Okay. So this name popped up in the options. There wasn't any question related to this, but then we got to know what is this actually occurring. We don't have to do anything over here. They will give you a slide that is neutrophils with bilobe nuclei. Bilobe nuclei. Okay. If neutrophils were with so many nuclei, it was hypersegmented neutrophil that is seen in megaloblastic anemia. But here, two lobes are there in nuclei, neutrophil. Okay. So if two lobes are there, think about pseudo Pelger-Hewitt anomaly. All right. Moving ahead. Now coming to the main part of the WBCs, and this is going to be difficult to catch, especially the CML and CLL type. I don't know what's the problem. Okay. All right, let's just start. Leukemias. Unregulated growth and differentiation of WBCs in bone marrow, marrow failure, anemia, infection, hemorrhage, everything will occur over here. Everything will occur over here. Okay. So now let's just skip this and come to the first part. ALL. Acute lymphoblastic leukemia, lymphoma. Okay. So let's just start. First, I'll tell you what's all important, then I'll add 2, 3 points over here. You need to write it down. Most commonly occurs in children. Most commonly occurs in children, and this is the difference that will be getting you with the CLL. Okay, we are confused between AML and CLL. Look at the age. If it is in older, greater than 60 years of age, your answer will be CLL. If it is children, ALL. This is the first point. Coming to what it can be, so let's just see. T cell ALL can present at mediastinal mass associated with Down syndrome. Peripheral blood and bone marrow have increase in lymphoblast. Okay, this is about T cell ALL. So this is one of the marker TDT plus CD10 plus may spread to CNS and testis. 1221, 922, best and worst prognosis. Just highlight this, then I'll tell you what to know. Forget about the worst prognosis. They never ask. 1221, very important. Okay, so your translocation is 1221. Another thing, TDT plus and CD10 plus, these are the markers. So this is also important. And another thing that you need to remember here is, if the question wants to ask you T cell ALL or B cell ALL, you need to look at the markers. If it is T cell ALL, they will say CD1, 2, 3, any positive. If it is B cell ALL, they will definitely give you CD19, CD20 positive. Okay. And overall, they will mostly ask you about the B cell only. Okay, they won't ask you T cell, B cell. This is the case in UWorld. One of the options was given T cell ALL, B cell ALL. So this is just how you will be distinguishing between the T cell and B cell ALL. Okay, But overall, they won't ask B cell and T cell AL, they will just ask ALL. Okay, so any of the markers can be possible, but more specifically being TDT plus, CD10 plus, T1221 is a translocation and occurs in children. That's all about ALL. Okay, moving to CLL. Most common adult leukemia. Okay, so these are the markers. These are all the B cell markers. Okay, asymptomatic and smudge cells. Smudge cells are very important. These are what the smudge cells. Okay, images are very important here. Same image will be asked in UL so many times on NBME everywhere. Okay, so just make sure smudge cells, how do they look. Now, what important is it also like there is a richer transformation over here, and this line is important. CLL SLL transformation into aggressive lymphoma, most commonly DLBCL. So DLBCL that we studied in the non-Hodgkin lymphoma is linked with CLL. Okay, aggressive CLL can turn to DLBCL. So this is what you need to remember here. Okay, in CLL, no translocation you have to remember. You need to remember that it occurs in age greater than 60 years of age. Second point, you have to remember the smudge cells. Third point, markers will be same B and T cells. Fourth point, you need to remember the Richter transformation that will be transformed into DLBCL. Okay, so this is what you need to remember here. Coming to hairy cell leukemia. Now, hairy cell leukemia is in its own class. There is no particular thing over here. Just one thing you need to remember is they are trap positive. And exam will definitely give you trap positive. Direct question. Okay. And what is there? Yeah, BRAF mutation is important. On myelofibrosis, it causes myelofibrosis. So try tap on aspiration. Yeah, one important point you need to remember, it is a lymphoma with massive splenomegaly and pancytopenia. Massive splenomegaly is very important. Okay, because in all other leukemia, we are not looking at splenomegaly. But in hairy cell leukemia, massive splenomegaly is very, very important. Okay, sometimes they might not give you trap positive. They might not give you the hairy cell leukemia. They will give you there was pancytomia. It is a B cell tumor. There was massive splenomegaly. Make the diagnosis. Hairy cell leukemia is the diagnosis. Okay. Now one important line: filamentous hair-like projection, fuzzy appearing on light microscope. Okay. This is what fuzzy appearing on microscope looks like, and this is what hairy cell leukemia looks like. All right. Moving to myeloid neoplasm. So this was all about the lymphoid neoplasm, ALL, CLL, and hairy leukemia. Moving to the myeloid, AML, CML. Now first come to the AML. Median onset 65 years or rods. Or rods are so important. Now see in this image, it is easily visible. In exam, it won't be easily visible. In exam, what they will do is they will just live like this. In the entire cell, only one small organism like this or rod. Okay, in UL also you must have seen ये और रोज एक या दो ही दे रहे हैं इमेज में, बट इन एग्जाम देयर विल बी ओनली वन. ओके, सो जहां पे भी ऐसा दिख रहा है डोंट इवन सेकंड गेस, straight away go for AML. Okay, or rods are very important. Coming back. Okay, myeloperoxidase positive. Okay, so most commonly they ask about M3 AML. Okay, see in the when you were studying for NEET PG or some other exam, there are so many classes of AML. Promyelocytic, megamyelocytic, 1, 2, 3, 4, so many things. They won't ask over here all those stuff. Okay, so just remember M3 AML, increase in circulating myeloblasts on peripheral smear. Okay, and another thing you need to remember here is the prior exposure is okay. Okay, yeah, this is T15, T17. 1517 translocation is important here. Okay, it responds to all trans retinoic acid. That's it. So here, if we go overall, you just need to remember OR rod and 1517. OR rod and 1517. Okay. ALL में it was 1221, AML में 1517. ओके गाइस, ट्रांसलोकेशन बहुत इंपॉर्टेंट है. डायग्नोसिस करने बोलेंगे एंड दे विल आस्क यू टू आइडेंटिफाई द ट्रांसलोकेशन. ओके, इट्स वेरी इंपॉर्टेंट. आई वांट यू टू मेमोराइज इट एनी हाउ. एक पेज पे लिख दो सारे ट्रांसलोकेशन एंड रिमेंबर इट. ओके, कमिंग टू द CML, peak incidence 45 to 80 years, defined by Philadelphia chromosome. Now, what is Philadelphia chromosome? 922 BCR ABL. 922 BCR ABL. Another translocation that you need to remember. Okay. Presence with dysregulated production of mature and maturing granulocytes. ये सारे हो जाएंगे. Splenomegaly can also occur in some cases. May accelerate and transform to AML, ALL, and response to BCR, ABL, tyrosine kinase inhibitors, imatinib. Imatinib is important over here. So now see how to identify CML. If they give you this big lymphocyte and you are not getting any history regarding AML, ALL, CLL, because you see all the other leukemia had some characteristic features with them. But CML के पास कोई characteristic feature नहीं है. Only one feature is there, and that is 922 Philadelphia chromosome BCR-ABL. Okay. One important point is in the UWorld or NBME, I don't remember. Instead of asking 922 BCR-ABL, what they did was they gave the chromosome as an option. चार option दिए थे, and they asked for how the translocation occurs. Okay. So translocation कैसे हो रहा है? एक का इधर आ जाएगा, एक इधर आ जाएगा, एक इधर आ जाएगा. So there was BCR and ABL translocation going on. So you have to identify translocation कैसे हो रहा है. Rather than just mugging up, they asked this NBME. It was a very notorious question because basically they tested back to the biochemistry basics translocation. Okay, so any type of question is possible in the exam. They just like you to play with the concept. Okay, so ये आपका हो गया ल्यूकीमिया बी. All right, so leukemia, as you know, very important and it feels difficult to diagnose sometimes, but all you need to remember is basic one line of information. All right, coming to the myoproliferative disorders, neoplasm, and these are also important because questions have been asked. All right, let's see. The first one is polycythemia vera. Primary polycythemia, disorder of increase in RBC, usually acquired due to JAK2 mutation, may present as intense itching. This line is important. Intense itching after shower. Aquagenic pruritus. Rare but classic symptom is erythromelalgia, that is severe burning pain and red blue discoloration due to episodic blood clots in the vessels of exudation, not needed. And yeah, with polycythemia vera, you have to remember this diagram. You have to actually ratify this diagram because they have asked about relative, appropriate absolute, inappropriate absolute PV, everything they have asked. Okay, you have to ratify this diagram if you don't understand how to ratify it, how to remember. Now sometimes, yeah, lab values, so of course you have to remember किसमें O2 saturation है, only in one. किसमें EPO levels decrease हो रहा है, only in one. किसमें plasma volume decrease हो रहा है, only in one. This you have to remember. I can't help you with this. I can help you with one thing is remember the cases. If they give you dehydration, it's relative. If they give you lung or heart disease, it is appropriate absolute. If they give you that the patient is using exogenous EPO और एंड्रोजन, इट इज इनएप्रोप्रिएट एब्सोल्यूट. ओके, और इसके अलावा कुछ भी आता है पॉलीसाइथीमिया वगैरह. ओके, so this is how you are going to remember and mark my word, this table is very important. यूएल में 2-3 सवाल है, एनबीएमई में भी सवाल है, in exam also you will be asked. Okay, so this was all about the polycythemia vera. Coming to the essential thrombocythemia. Okay, essential thrombocythemia. तो इसमें देखते क्या है. Characterized by massive proliferation of megakaryocytes and platelets. RBCs का कोई रोल नहीं है यहाँ पे. Symptoms include bleeding and thrombosis, Blood smear shows markedly increased number of platelets which may be large or otherwise abnormally found. Big platelets. Big platelets. Okay, so this is essential thrombocytopenia. Now, if in the question they ask which is the most lenient this myoproliferative disorder, so this is essential thrombocytopenia. It's not very severe. Okay, it's very mild. Okay, coming to myelofibrosis, that is the last one. Atypical megakaryocyte hyperplasia. Okay, increase in TGF beta secretion, fibroblast activity, obliteration of bone marrow with fibroblast. Fibroblast हो जाएगा. TGF beta we did in immunology. It is an anti-inflammatory. Fibrosis कराता है. Associated with massive splenomegaly and teardrop RBC. Teardrop RBC. This is what teardrop RBC looks like. Okay, teardrop RBC. Now, one important point I want to tell you is कि sometimes in exam what happen is they will give you a slide and all types of morphologies are there. There is teardrop, there is sickle cell, there is helmet cells, everything is there. And at that point you will be confused कि साला कौन सा disease select करे. That's where you have to look at the case. Okay, and that's where the hematology becomes difficult and confusing. Because they will be giving you 2 3 morphologies of RBC in the same question. Now how you will pick it out? Okay, so you need to keep this in mind, and that's all for a chronic myeloproliferation. Just give me 2 minutes. All right, moving ahead. So here the first aid has already given the summary. So ये translocation you can write it down, and I think all of them are covered except one 1221. That is for ALL. Okay. Now yeah, this is important over here. Langerhans cells histocytosis is important. Langerhans cells. Proliferative disorders of Langerhans cells. Antigen presenting cells normally formed in skin, presenting child as a lytic bone lesions. And one important point that was remember here is yeah, S100, CD1A. These are the markers you need to remember. And Burbeck granules, tennis rackets or rod chip. Easily remember. टेनिस रैकेट जैसा इजीली दिखेगा और रॉड चिप तो टेनिस रैकेट दे मोस्ट कॉमनली आज ओके टेनिस रैकेट देंगे so if you can't understand the question leave it just remember the tennis racket okay we are done with Langerhans cell histiocytosis. Tumor lysis syndrome, they like to ask this also regarding the ions part. Okay, what is there? सब कुछ increase होगा except calcium. Okay, so with this we have finished hemat, RBC, WBC, platelets सारे disorders cover कर लिए. Now we will be doing pathology. pathology is a little bit difficult here also because some other drugs that you have to memorize them. जो लास्ट पेजेस में एंटी ट्यूमर ड्रग्स है, you have to memorize them. So let's just discuss pharmacology for quickly, and then we'll start with the skin in musculoskeletal system. All right, heparin. What you need to remember in heparin is in this edition they directly started with heparin, whereas in 2020 it was direct thrombin inhibitors. No problem. Let's go with heparin. All right. Activates antithrombin. The mechanism to you have to remember anyhow. Okay, mechanism to you have to remember anyhow. Coming to the clinical use, now heparin and warfarin they are used in so many cases. Okay, they are used in so many cases. So mostly the step one is not going to ask you where it is used. Okay, but still UL में एक दो question है. So let's just note it down. DVT, pulmonary embolism, and it is used during pregnancy. Okay, now to monitor heparin, one question is already every time asked PTT. We will measure by PTT. Okay, heparin PTT. Now let's see the adverse effect. Heparin induced thrombocytopenia HIT1 HIT type 2. We discussed this कि अगर आपको केस में heparin आया so what will be your answer? Either heparin induced thrombocytopenia or और कौन सा था दूसरा syndrome? Come on, quickly tell me. What did we discuss? If there is heparin in the case given, either it can be this, and the second one was
Antithrombin deficiency.
yeah, antithrombin deficiency. These are the two cases when you have to be alert when heparin is given. Okay. Now coming to type 1 and type 2, they have never asked. Okay, but in type 2, they have asked this one point: development of IgG antibodies again heparin factor platelet factor 4. Okay, they have asked this. So this is important, and yeah, highest risk with the unfractionated heparin. Treatment is discontinuous heparin, start alternative anticoagulants, agatropine. Fondaparinux safe to use because it does not interact with PFO. All these are one liners. Another important point: antidote for heparin. You have protamine sulfate. Okay, this is the antidote. You have to remember this. Now see what are the important points. Low molecular weight heparin, that is enoxaparin, dalteparin, act mainly on factor 10A. Fondaparinux acts only on factor 10A. Both are not easily reversible. Unfractionated heparin used in patients with renal insufficiency because they undergo renal clearance. Okay, so this is what you need to remember here. These are the notes. HIT type 1 you can ignore, but type 2 you have to remember what mechanism is. You need to remember the antidote. The most commonly asked in UL, this was given in pulmonary embolism and DVT, heparin was used, and mechanism you need to remember. That's all about the heparin. Just one point you have to write. What was the point? Yeah. So sometimes they will give you pregnant female. So in pregnant female, you will use unfractionated heparin. Why? Because it is eliminated by liver. This was the given in NBME. Okay. All right. That's it. Let's move ahead. Warfarin. Now heparin and warfarin always is the differences you have to remember. So let's just see about warfarin. Inhibits vitamin K epoxide reductase by competing with vitamin K. Inhibition of vitamin K dependent gamma carboxylation of floating factor is this. Okay, we saw this in the beginning of this class in the physiology part. Vitamin K ka 2, 7, 9, 10 protein C and protein S. Don't forget protein C and protein S. Okay, metabolism affected by polymorphisms in the gene for vitamin K epoxide reductase. No problem. यहाँ पे they have to monitor with PT. In heparin P double T. Okay, clinical use again mostly same use होते हैं दोनों के heparin and warfarin. We just look at what can be given and based on the situation. Okay, but one thing is it's not used in pregnant female crosses placenta. Okay, so let's just see adverse effects. Adverse effect may remember this image. This image is going to be going to comfort you. Okay, teratogenic है, bleeding है, skin tissue necrosis. This is what necrosis is. And yeah, it is metabolized by cytochrome P450. Yeah, in the uval last class also I told you, whenever you are solving the question and you come across CYP 450 something like this, they ask about inducers and inhibitors. वो that remember that table, वो table निकाल दो and remember it. Okay, प्लीज CYP 450 के क्वेश्चन आएंगे इन NBME. So many are there, UVL so many are there. Inducers and inhibitors, you have to remember them. 4 to 5 inhibitors, 4 to 5 inducers. Okay, so और क्या है इसमें, स्किन टिश्यू नेक्रोसिस आपको याद करनी है. For reversal give vitamin K, for rapid reversal give FFP or PCG. That's it, nothing more in warfarin. Okay, that's it for warfarin. Mechanism is important. PT say you have to monitor. And necrosis, this is the side effect most commonly asked in the exam. Okay, now coming between the differences: administration route oral and parenteral, site of action blood and liver, onset of action rapid and slow, duration of action hours and days, monitoring PWT cross placenta no yes. So all these are the basics. This will help you diagnose between the difference between them. Okay, coming to direct coagulation factor inhibitors. First one is direct thrombin inhibitors. Another name is direct thrombin inhibitors. Okay, mechanism is must remember the drugs, and it can be used when heparin is not used. Okay, see here also clinical use, it can be given anywhere because it depends on the situation. So adverse effect bleeding. Now see, one important point I want you to know is whatever the anticoagulant drugs you give, bleeding is common side effect, complication you can say. Whatever anticoagulant, whatever drug for blood thinning, blood, all those stuff, bleeding is the common side effect everywhere. Okay, instead of bleeding, they may use the fancy term hemorrhage. Okay, so just make sure you don't get confused. Dabigatran is the only oral. Okay, does not require monitoring. Now coming to second type, directly inhibit factor 10A. Directly inhibit factor 10A. Okay, you can see from the name only Saban, Saban, 10A band, 10A band. Okay, so ignore this. Bleeding is the common side effect I told you. Reverse with Adaxanet alpha. This is very underrated, but asked in the in NBME it was asked. Okay, so these are the drugs. See, in hematology, pharmacology, they will give you the mechanism and you have to identify the drug. They will give you the drug, you have to identify the mechanism. Okay, this is very important because sometimes you will be confused here. Directly inhibit factor 2A or directly inhibit factor 10A. Okay, moving on to next, we have anticoagulation reversal. We have discussed this already. Okay, अभी आते हैं antiplatelet पे. First one is aspirin. Aspirin irreversibly block COX, decrease in thromboxane release. Okay, ignore the clinical use. Adverse effect is important: gastric ulcer, tinnitus, allergic reactions, and renal injury. This is important. Okay. Coming to clopidogrel, prasugrel, ticagrelor, ticlopidine. This and this. Don't confuse. Both seem to appear same, but somewhere the see both seem to appear same, but somewhere difference is there. Okay, don't confuse. They will ask you for sure. Ignore this. Neutropenia is important for your ticlopidin. TTP may be seen and bleeding and thrombocytopenia. Bleeding is common everywhere. Okay, coming to silostazole and dipridamol, block phosphodiesterase, increase in camp in platelet. Okay, camp hydrolysis कम हो जाएगा, camp platelets increase हो जाएगा. Ignore this. Nausea, headache, facial flushing, hypotension, abdominal pain. Another general rule: whenever there is phosphodiesterase blocking, always there is going to be flushing. Why flushing? Because of vasodilation. Okay, so these are all the drugs that you need to remember. Coming to thrombolytics, in thrombolytics you have all these drugs. Remember the names. Names are very important because names is what will get you the mechanism. Okay, directly or indirectly aid conversion of plasminogen to plasmin. This mechanism is important. Clinical use, ignore it. Coming to adverse effect, bleeding is common. Contraindicated in patients with active bleeding, history of intracranial bleeding, recent surgery, severe hypertension. Okay, guys, this line is very important because in the UL there is one question: where is this thrombolytics indicated? Where is this TPA breakdown like a sorry thrombolytics TPA kinase inhibitors are contraindicated. They will give you, and in UL has one question also. Okay, so these are the conditions where you should not give thrombolytics. That is active bleeding, history of intracranial bleeding, कोई surgery है, diarrhea or hypertension. All those you need to pick this up. Okay. Non-specific reversal with aminocaproic acid and transaminic acid. Okay, so all these one liners, these are all one liners, and in pharmacology they won't trouble you. They will directly ask you one liners. Okay, they won't trouble you. Directly one liners पूछेंगे आपको. Okay, so make sure your hematology drugs are good. With this, we are done with hematology. Now we have oncologic drugs, anti-tumor drugs. Okay, yeah. Remember this diagram. They will ask you G1 phase में कौन सा है, F1 phase को कौन सा है, S1 phase को कौन सा है. So this is a visual representation of all of that. Okay. Moving on to the first, we have anti-tumor antibiotics. Ignore this, not needed. One thing is anthracycline is very important here. Remember the mechanism and cardiomyopathy. What is important here is in the question they will give you this was used, and along with that now they will ask you side effect. So side effect is always going to be heart related. Okay, it's not necessary dilated cardiomyopathy हो. It can be anything. Heart related कुछ भी दिख रहा है, straight away go for this. और अगर they have given this और options में dilated cardiomyopathy नहीं है, but anything else is given related to heart, go for it. Okay, bleomycin here, pulmonary fibrosis. Okay, remember this, and pulmonary fibrosis, bleomycin, pulmonary fibrosis. That's it. Moving ahead, antimetabolites. Antimetabolites में युवल का ये फेवरेट है. So many questions have been asked on thiopurine. Okay, so just remember this mechanism. तो आपको सब में ही याद रखने. Okay, mechanism you have to remember in all of them. Uses में rheumatoid arthritis, all the chronic disease में you give azathioprine and mercaptopurine along with methotrexate. Okay, so see again the step one is not going to ask you about the uses and everything. Okay, because this is all part of step 2 CK. Okay, so you can avoid clinical uses. Okay, no problem for it. Adverse effect याद रखने हैं, myelosuppression. 6-MP is inactivated by xanthine oxidase to increase toxicity with allopurinol and febuxostat. And the favorite question of you will is if you are given this, don't prescribe allopurinol. This is so many times I have seen on UL and even in NBME. If you have given azathioprine or 6-mercaptopurine, don't give allopurinol. And why? Because this is the mechanism here. They have asked mechanism as well as the name of a drug, what should not be given. Okay. Coming to cladribine and pentostatin, remember this, myelosuppression. Cytarabine, remember this, myelosuppression. Pyroluryl, remember this, myelosuppression. Hand-foot syndrome is important here. Okay. Hydroxyurea, remember this, myelosuppression and megaloblastic anemia. Methotrexate, remember this. And in methotrexate, they have asked about so many questions regarding side effects. Myelosuppression तो सब में ही है. Reversible with leucovorin. This is one important question in U world. Methotrexate दिया. Now he wants to reverse the symptom, reverse the side effect. Leucovorin is very important. Okay. Leucovorin का दूसरा नाम है फोलिनिक एसिड. कंफ्यूज नहीं होना है. ल्यूकोवोरिन का दूसरा नाम है फोलिनिक एसिड. ओके. सो मेटोट्रेक्सेट टॉक्सिसिटी है, फोलिनिक एसिड दे दो. ओके. हेपेटोटॉक्सिक म्यूकोसाइटिस. म्यूकोसाइटिस is another important. Oral ulcers, they will give you oral ulcers are occurring after consuming this drug, methotrexate. Pulmonary fibrosis. Pulmonary fibrosis is also important. And nephrotoxins. So all of these are very important in case of methotrexate. Okay. So see, ये पेज में this is important. Cladribine is important. Hydroxyurea and methotrexate. These four drugs are very important. बाकी के दो आप just देख लो, no problem. But these four are very important. In one of the UL questions, what they did was instead of using cytarabine, they gave this name. We got confused. Okay. So बाकी के चार तो important है, but ये आप मिस नहीं कर सकते, आपको go through करना ही पड़ेगा. Okay. And in methotrexate, don't forget this folinic acid वाला. मेरे को एग्जाम में भी आया था. I was asked in the exam also, folinic acid और leucovorin, and in NBME also so many times have been asked. Okay. Alkyl lighting agents. Mechanism तो आंख बंद करके करना ही है. I don't have to say that. Busulfan, most commonly asked is pulmonary fibrosis. Nitrogen, cyclophosphamide. यहाँ पे भी pulmonary fibrosis है नहीं है. Okay, so here there is myelosuppression, SIADH. SIADH is important here. Cyclophosphamide के साथ SIADH is important. Cystitis and bladder cancer. And how you will prevent it? Mesna. This is also asked in UL so many times. Okay. Nitrosoureas, carmazine, lomazine. CNS toxicity. Okay. Procarbazine, disulfiram-like reaction. Pulmonary toxicity. Now see one thing I'm making you write down. Pulmonary fibrosis causing drugs. एक आगे we saw bleomycin. Then you have busulfan. Then you have cyclophosphamide. इसमें नहीं दिया है but लिख लो. You have carmazine, that is nitrosoureas, and procarbazine also. Okay. Now you can see one hint in this. Bleomycin को छोड़ के bus, cycle, car, car. All the vehicles are there. This is how you'll remember drugs causing pulmonary fibrosis. Okay. So note this down. This is a new drug. Never been asked. Never saw in NBME. छोड़ दो. Platinum compounds. Okay. Before that, let's do microtubule inhibitors. M phase specifics, and I rate them as very very high yield. बहुत बार पूछा है, बहुत बार. Okay. Taxanes, hyperstabilized polymerized microtubules, prevent mitotic spindle breakdown. दोनों में ये बहुत ही important है, very important. Direct one liners आया है. Okay. Myelosuppression, neuropathy, hypersensitivity, and in vinca alkaloid, vincristin and vinblastine. Okay. So ये बहुत important है, very very important. Every time the questions have been asked, and UL has also asked it so many times. Okay. ये सारे ड्रग में भी दे वोंट ट्रबल यू. डायरेक्ट वन लाइनर. मैकेनिज्म दिया है, ड्रग आइडेंटिफाई करो. ड्रग दिया है, मैकेनिज्म आइडेंटिफाई करो. साइड इफेक्ट्स आइडेंटिफाई करो. ओके. डायरेक्ट वन लाइनर क्वेश्चंस विल बी कमिंग हियर. मूविंग अहेड. Topoisomerase inhibitors. You will confuse between 1 and 2. Remember the drug name 1 and 2. The side effect will be myelosuppression and diarrhea. That's it. Myelosuppression. Okay. Tamoxifen. It is some drug. SERM drug. SERM. Okay. Antagonist in breast tissue. Partial agonist in endometrium and bone. Blocks the binding of estrogen. Okay. और कुछ नहीं है. One important point you need to remember here is hot flashes and increased risk of thromboembolic event and endometrial cancer because it is going to increase estrogen. Okay. एंटी कैंसर मोनोक्लोनल एंटीबॉडीज क्या था? Oh wait, I forgot something here. Yeah, platinum compound. Cisplatin is very important. Remember the mechanism. And another thing is nephrotoxicity and autotoxicity. In UL, they have given nephro and auto. Okay, cisplatin. Coming to the anti-cancer monoclonal antibodies, सारे याद नहीं करने. You don't have to remember all. I'll tell you what you need to remember and do that with utmost care. Okay. Bevacizumab is important. Rituximab is important. Trastuzumab is important. Here, pembrolizumab was I have seen somewhere. Yeah, pembrolizumab we saw in immunology. Okay, immunology में देखा हुआ है. So just remember this. Rest all you can avoid. Now इसमें क्या क्या important है ये? VEGF है तो एंजियो प्रोलिफरेटिव के लिए मतलब एंजियोजेनेसिस के लिए काम आएगा. Now here CD20. CD20 so CLL and non-Hodgkin lymphoma it will be used because you have seen CD20 B cell marker. So B cell का जहाँ पे भी deficiency होगा CD20 will be used. Okay. Trastuzumab again dilated cardiomyopathy. They will say breast cancer. Trastuzumab was given and in the side effect heart problems से. Trastuzumab dilated cardiomyopathy. Okay. That's it. Here what you need to remember here is erlotinib you have to remember. Imatinib you have to remember. Rixotinib you have to remember. Bortezomib you have to remember. And yeah, that's it. That's it. Why you need to remember this? Erlotinib के मतलब इसमें आ जा रैश डायरिया का एक सवाल आया था. इमाटिनिब बीसीआर एबीएल तो ये यू नो सीएमएल के लिए इंपॉर्टेंट है. ड्रग का नाम भूल गया. रुक्सोलिटिनिब. रुक्सोलिटिनिब बिकॉज जैक 1 ओके जैक 2 म्यूटेशन तो वो सब में काम आ सकता है रुक्सोलिटिनिब एंड दिस वाज आस्क्ड इन यूवल. ओके. बोर्टेजोमिब इक्साजोमिब कार्फिलोजोमिब प्रोटिएजम. ओके. so ये मल्टीपल माइलोमा के ड्रग्स है. दिस वेरी इंपॉर्टेंट. जोमिब जोम्बी ड्रग्स आर यूज्ड फॉर मल्टीपल माइलोमा. ओके. दैट्स इट. दैट्स इट. ये सब तो आप उसके साथ ही कर सकते हो. यू कैन अवॉइड दिस. दिया हुआ नहीं है पुराने एडिशंस में. सो नो नीड टू remember this. This is a drug. This is a very good hint and diagram that they have made. Look at this and look at this all the structure. ये सब hint. Okay. So with this we are done with hematology and oncology and सारे drugs बता दिए. We finished RBC, WBC, platelet disorders and everything. Okay. So guys, it's up to you. Should I start skin now or kal? Whatever you say, I'm okay. Just let me know.
Tomorrow.
कल करूँ? Okay. Okay then. Tomorrow we'll start with musculoskeletal, but then tomorrow I won't start skin. I will start from bone tumors only, and I'll try to finish the entire musculoskeletal tomorrow. Okay. And okay, no problem. And one more thing is, if you guys are not going to come tomorrow, तो मुझे advance में बता देना because I have to record it. Okay. So if अगर कोई नहीं आ रहा है, so I will take it in the afternoon. I'll take it in the evening. और रात को एक और session ले लूँगा and I will try to finish it out because at the end you will be watching the recording. So जितना जल्दी मैं खत्म कर दूंगा उतनी जल्दी recordings आपको मिलेंगी. Okay. So I hope you are getting my point. So मुझे बस inform कर दिया करो कि you are not going to attend today. It's okay. It's completely fine. You can watch the recording later. Okay. So I always message you in the morning बस मुझे मैसेज कर दिया करो आई वोंट बी एबल टू अटेंड टुडे, सो दैट आई गेट द आइडिया कि कौन एक बंदा आ रहा है, तो मैं उससे कम्युनिकेट करके मेरे टाइम के अकॉर्डिंग मैं उससे क्लास ले लूंगा. ओके, आई होप यू आर ट्राइंग टू गेट व्हाट आई एम ट्राइंग टू से. ओके, सो टुमारो विल स्टार्ट मस्कुलोस्केलेटल. रिवाइज करके आता ना, विल डिस्कस इट एंड फिनिश इट. Alright, if you have any doubt in hematology, let me know, or else the class is over. And if you want to talk personally, uh, बता दो, मीटिंग बंद करके बात कर लें.